Our next speaker is Dr. Zeev Shoham from Rehovot in Israel. Dr. Shoham is the co-founder of the IVF-WorldWide, and that's one of the largest websites on in vitro fertilization.
Chairman, ladies and gentlemen, good afternoon. I'd like first to congratulate you, John, for extremely high scientific level of this program. You know, I'm traveling a lot, and I'm amazed by the number of scientists that you gathered in this room for the last 2 days. It's really amazing. My lecture is much more simple. I'm a clinician, and I'll try to look at how can we improve pregnancy rate in IVF using the time-lapse system. So where can we improve the IVF? IVF we are doing for the last 35 to 40 years. It's become a very simple procedure. We stimulate the patients, we retrieve the oocytes, fertilize them, then we try to select the best embryo and replace it into the uterus, transfer it, and hope that it will end with pregnancy. Unfortunately, only around 5% of the oocytes that we are retrieving are ended in live birth rate. So we're aiming to have a singleton pregnancy, and we are trying to be very careful with the embryo selection and with the transfer procedure. Recently, a technology was improved, and the time-lapse technology was introduced into our practice, which enable us to do a few things. First, we are writing a new chapter in the field of IVF. Secondly, this machine can serve as an excellent tool for research, and it supports, or I think it supports, the selection of the best embryo to transfer. If you look at the usual microscope, you see that embryos look like the same. And the question is if they are all the same. So within the standard incubation, the principle of choosing the most competent embryos for transfer are morphological parameters and the rate of cleavage. And if we look at a study which was published 5 years ago, it was the Istanbul Consensus Workshop on Embryo Assessment proceedings of an expert meeting. And this was a combination of the alpha scientist people trying to look at the best embryo. How can we define the best embryo to replace? Based on few parameters. One is the time of the cleavage time for 2 cells, which is at that time, they thought, considered as a strong predictor for embryo implantation. And the other one is the positive selection criteria, including the absence of multinucleation, homogeneous in blastomers, size, and low percentage of cell fragments. There is very limited ability to accurately predict the reproductive potential of an individual embryo. And the development of an accurate method to better choose the most competent embryo is currently one of the main challenges of ART. So what we have today is actually we are looking at the cleavage rate, and we're expecting the embryo to divide into 2 cells within 25 to 26 hours, 4 cells within 42 to 44 hours, and 8 cells between 66 to 68 hours. When the time-lapse came in, the whole chapter was changed, and we look at different things today. One, the time-lapse available a dynamic evaluation and better selections of embryo. It's an undisturbed culture system and stable environment. It did when we want. We can look at the embryos wherever we want and whenever we want, and we can even look at the embryos when we are far away from the laboratory, and we compile data that can analyze at a later stage. So instead of opening the standard incubator very frequently, we can actually put the embryo in and look at the time of wherever we want, and we can replace the embryo in 3 or 5 days, wherever we think, without opening the incubator. Most important is complying data. This is an electronic device, and we compare previous cycles to improve the assessment of the embryo. We can look at re-evaluating data at the best novel hypothesis, and we actually have a simple quality control on gas, temperature, and everything we would like to have within the laboratory. So allowing embryo observation for outside the laboratory, which today is very simple through the internet. And based on all the above, and what I mentioned, several algorithms for embryo selection were developed. And I would like to show you something which is a little bit different. There are lots of papers published in the literature about how to select embryo after 3 days and after 5 days, but we developed a different system. And I want to show you 2 papers which we published. One we published several months ago, looking at the irregular cleavage of early implantation human embryos, characteristic of patients and pregnancy outcome. And we look at 253 women who had gone through 387 ICSI treatment cycle. 15.6% of the cycle of the embryo had irregular cleavage out of 1,700 embryos that actually developed. So you can see here the normal embryo development, but what I would like to show you that we can identify with the embryoscope quite clearly if there is irregular development from 1 to 3 or 2 to 5 cells. And this makes a lot of difference. And you can see on the video now a cleavage from 1 to 3 cells. And the interesting thing is that the embryo continued to develop and look like a very normal blastocyst.
Start of respiration, blastocyst, second polar body experiment. Ponuclei appear, top 2 ponuclei. Ponuclei faded, cleavage into 2 cells. Irregular cleavage from 2 to 5 cells.
And again, this embryo developed to blastocyst, and actually they look the same.
Respiration, blastocyst.
However, when we transferred, and we actually usually transferring only one embryo, we think that single embryo transfer is very important. And when we had no other embryo, better embryo to transfer, we transferred either the one who cleaved from 1 to 3, or in other patients, the 2 to 5. And embryo that cleaved from 2 to 5 gave human live birth, normal live birth baby. Embryo who cleaved from 1 to 3 did not end in pregnancy. But if you don't use the embryoscope and you follow the development, you think that both blastocysts are actually the same. So this is a way that we can use the embryoscope in a better way than just using the microscope. Another paper which is due to publish, I think, this month, is about the ratio between the inner cell mass diameter and the blastocyst diameter, which is correlate with successful pregnancy outcome of a single blastocyst transfer. And what actually, the transfer of a single blastocyst has been considered a better option than the transfer of a cleavage stage embryo because embryo endometrium synchronicity and better odds of transferring a viable embryo. Also, there is a paper published by Gardner and Schoolcraft scoring assessment of blastocyst and the expansion stage, the inner cell mass, and looking at the trophoectoderm. So positive correlation between the inner cell mass and the blastocyst viability was shown previously. So what we did is we look at women with autologous fertilized oocytes, embryos culture continuously in the embryoscope, and a single embryo transfer, and irrespective of the woman's age, cycle number, and reason for treatment, we transfer single embryo transfer. So we measured the blastocyst in between 114 to 116 hours after the ICSI procedure. And we look at the inner cell mass to blastocyst ratio, which was defined as the inner cell mass diameter divided by the blastocyst diameter. And you can see here the photo taken from the embryoscope, and you can see that there is a caliper on the embryoscope that you can measure the inner cell mass, and you can measure the blastocyst, and you get the ratio. You can see the ratio, which is 55 to 128. So this is the way we measured inner cell mass and blastocyst ratio. So we look at 132 blastocyst transfer, which performed in 114 women. We had 37 clinical pregnancies, 28% per transfer, and 32% per women, and the average age was 35. In 51 women, which is 45%, the blastocysts were in the initial stage of blastulation, and the relative size of the inner cell mass could not be determined, so they were actually excluded. So we had 63 women, 65 single blastocyst transfer, and you can see on the left side that there were 25 pregnancy, 38% per transfer, 40% of the women, average age was 32, and the inner cell mass versus the blastocyst ratio was 0.487. On the left side, you can see the 38 non-pregnant women, 60% of the women, with a ratio of the blastocyst, of the inner cell mass versus the blastocyst, 0.337. And we found that this was significant. So we went into stage 2. This was a retrospective analysis. Now we look into a prospective analysis, and we look at 64 women, and the aim was to transfer one blastocyst with more than 0.46 inner cell mass blastocyst ratio, and we look at the clinical pregnancy rate. As you can see, in phase 1, we have 63 women, pregnancy rate 25. In phase 2, we had 64 women, and the pregnancy rate, or number of pregnancy, was 43. So the pregnancy rate was almost 67% per single embryo transfer when it matched the criteria. So if we compare the phase 1 and phase 2 in this table, you can see that the number of pregnancy almost double itself if you can know how to choose the right blastocyst. And the problem is that you cannot see it by eyes. You know, the blastocyst looks the same. But if you measure the ratio between the inner cell mass and the blastocyst, then you find this difference. So you can see here, two blastocysts look the same with different ratio. One ended with pregnancy, and the other one did not. And you can see here how it's being done. This looks a very bad blastocyst, which found with a very good ratio and actually ended with pregnancy. So I'd like to conclude the presentation, and I think that we can say that our results indicate that the high inner cell mass versus blastocyst ratio is associated with significantly increased pregnancy rate. The inner cell mass to blastocyst diameter ratio, when calculated using the Time-Lapse Microscopy, is a predictor of implantation and live birth in single blastocyst transfer, offering a simple, non-interfering method to select blastocysts with high development capacity. And it is suggested that the diameter ratio, as measured in the study, correlates with the number of cells of the inner cell mass. So it shows that when you have more cells in the inner cell mass, the chance that this blastocyst will end in pregnancy is higher. And I found this quotation in a paper published this morning in Human Reproduction Update by Danny Sakas, where he reviewed the time-lapse there, and he wrote, "A deeper analysis of the time-lapse data will in the future allow us to develop algorithms which estimate not only cell number and time, but more components, including cleavage plane and position of each cell. This data will help us more accurately predict not only which embryo will lead to a healthy live birth, but also provide insight into the genomic and metabolic tendencies of each individual embryo." Thank you very much.